Right, well today the subject is arrhythmias. And arrhythmias can be as simple or as complex as you like to make them. But basically all arrhythmias are really due to one of three basic mechanisms. Right? Increased excitability of tissue, decreased excitability, and then conduction disturbances. So any arrhythmia that you see, you can eventually break down into one of these or more of these mechanisms. Sometimes they can be combined. And if you just keep this basic outline in mind, it'll sometimes help you understand a lot about arrhythmias as well. Another thing that's very helpful, I've found with arrhythmias, is to get yourself a pair of calipers. They're not very expensive. I don't think they cost between $5 and $10. And they can make all the difference in the world in terms of an arrhythmia being fun and interesting or just being very difficult and a threat to you. Okay, well, let's just take an example now. Suppose you have an EKG, looks like this. You have a beat. Now here's the same EKG going along, except here, this beat, which is exactly the same as this one, appears late. In this situation, you're dealing with what? This is a premature beat, right? This is a premature ventricular contraction, right? And this looks exactly the same, but it really isn't a premature ventricular contraction. Okay, now this one is an example of what? Which of these three mechanisms? A PVC, irritability, is an example of increased excitability, right? Now this one is an example of, this would be an example of, well actually it could be a conduction disturbance, but more likely it's an example of a decreased excitability. And what's happened here is that there was decreased excitability of, let's say, the SA node of the junction, and then after a long period of time, the ventricle escaped. This is an escape beat, escaped at its own intrinsic rate. So let's take a look at this now. We have in the heart a defense in depth system. So the SA node goes along at its own intrinsic rate, which is about what? About 80, and the junction, or the node, 60, and the ventricles, the idioventricular rhythm is, right, about 40. So you can see what's happened here now. This is an example of a premature beat, example of irritability, right? Whereas here, the upper mechanism has stopped firing, the node did not take over, and finally the ventricle took over at its own escape rate of approximately 40. So even though these beats may look exactly alike, they are quite different. Even though they can't come from exactly the same focus in the ventricle, their mode of genesis is really completely different. It's a different mechanism. One is increased excitability, and the other one is decreased excitability. Okay, now, this system of considering arrhythmias, really a function of these mechanisms outlined here, helps to explain, for instance, the toxic manifestations of digitalis in electrocardiogram, for example, digitalis toxicity. Now, if you really think about it, digitalis toxicity is not just any arrhythmia that can be produced, as some people, well, I think when we all go through our training, I think we all get the impression that you can just about get any arrhythmia imaginable with digitalis. At least that's what I was thinking at one point. But it's not really so. Okay, you have a digitalis which will produce arrhythmias because of its enhanced effect on automaticity. So you have irritable manifestations due to increased excitability, right? These are such things as PVCs, nodal tacks, ventricular tach, ventricular fib, right? Nodal premature beats, atrial premature beats, all kinds of irritable manifestations, right? these are very common, very common electrical problems produced by digitalis in the heart. And the other thing that digitalis does is produces conduction disturbances, right? And we very frequently see examples of AV block patients taking digitalis, right? First-degree block, and then if they start to get toxic, well, actually, first-degree block may be considered a sign of toxicity, and then higher degrees of block all the way right through to complete heart block, right? So this is what digitalis does, really. It increases the irritability of myocardial tissue, and it decreases the conduction through the AV node. So you get heart block, produces conduction disturbances through the AV node, right? Okay, so, and this is also important from a therapeutic point of view, because if a patient is dig-toxic with manifestations of increased excitability, this you treat with K, potassium, right? These are treatable by potassium, and they will respond. However, if you treat patients with AV conduction disturbances with potassium, very dangerous, contraindicated, and it can be lethal, right? So it's good to keep this outline in mind when you're thinking about digitalis toxicity. It's a good way to think about digitalis toxicity and get some of your thoughts organized on that subject. Okay, now this outline also, if you understand this outline, you can also understand the difference between complete heart block and AV dissociation. This is something that I know always confuses a lot of people. They use the terms interchangeably, and they're really not the same thing. Sometimes it can be a little difficult to distinguish the two, but basically, from a theoretical standpoint, there should be no difficulty in distinguishing the two, right? Because what do you have in complete heart block? Which one of these three mechanisms is operable in complete heart block? Conduction disturbances, right? Certainly that. Okay, so this is complete heart block. Now, how about AV dissociation? What do you have? In AV dissociation, you do not have a conduction disturbance. You have a problem with increased excitability of lower pacemaker tissue, right? So this is AV dissociation. So in AV dissociation, what you have is that the lower focus is going faster than the upper focus. In other words, take a patient that has ventricular tachycardia. Ventricular tachycardia is an example of AV dissociation. The ventricles are firing faster than the atria, and they're taking over the rhythm. Okay. What do you see occasionally in these electrocardiograms in patients with AV dissociation to show you that they do have conduction? They do have normal conduction. You see a certain kind of beat that tells you do have a normal conduction. The presence of what kind of beats? Capture beats. Capture beats. So they come through from above. You have the atria going along at one rate, and you have the ventricles going along much faster. Right? So this would be, say, a ventricular tachycardia. Right? But every now and then, you can see this would be a wide QRS complex, being a ventricular tachycardia. And let's say at this point here, you can see a normally conducted beat right in the middle of all of these wide QRS complexes. That tells you have conduction coming down, and this would be a capture beat. And if they're mixing with this other beat, we call it a fusion beat. Then it would be a fusion beat if it's mixing with the ventricular beat or the beat from the lower focus. Okay, but you see the basic idea is that complete heart block, you have a disturbance of conduction. Here's the atria, here's the ventricle. In the complete heart block, nothing is getting through. You see that? Whereas in AV dissociation, all the impulses could get through, but the lower focus is beating the upper one to the punch, so to speak. Right? So the lower focus dominates. That's AV dissociation, the difference between AV dissociation and complete heart block. And again, it's good to go back to this outline. Okay, any questions about that? Okay, if not, then we'll go on, and we'll first talk about the atrial arrhythmias. And we'll divide the atrial arrhythmias into those that appear regular and those that appear irregular. Well, first we'll talk about the regular atrial arrhythmias. And then we'll start out with the slowest and then speed up. So what's the slowest atrial rhythm? What do we call it? Pardon? Bradycardia, sinus bradycardia, right. Sinus bradycardia. And the rate for sinus bradycardia is what? It's less than 50. Less than 50 per minute. Okay, and the next fastest, let's speed up here. As we're going faster, what do we have next? Right, normal sinus rhythm. And the rate for sinus rhythm is between what and what? What are the ranges? Between 50 to 100. Some people say 60 for sinus rhythm, but we see so many normal individuals, especially young individuals, who have rates between 50 and 60 that I would think that sinus bradycardia should be really less than 50. All right, and then as we speed up again, what's next? Sinus tachycardia. Sinus tachycardia, and the rate for sinus tachycardia goes from what? 100 to, well, 160 is about top, but we'll just, keep it simple here, we'll say 150, okay? And the next fastest then? No. No. We have a few more here. Nope. PAT, right? Paroxysmal atrial tachycardia. Paroxysmal atrial tachycardia, and the rate for paroxysmal atrial tachycardia is 150, right, to what? To 250, roughly. Okay, these are just very rough rate ranges. You can have some that will be out of these ranges, but these are just guidelines because these rates aren't that perfect for differentiation of these arrhythmias. They're just guidelines. Okay, and then PAT will divide into two types. One is we'll call the regular appearing PAT, the kind we're all familiar with, and then we have another kind, which is the digitalis-induced PAT, okay, which is different. And it's important to distinguish that from the regular type. Then as we go faster, we have what? Flutter. And the rate of flutter? 250 to what? To 350. Up to 350. Okay, and then finally, atrial fibrillation. But this is regular, right? But atrial fibrillation is irregular. But when you get an atrial fibrillation with a very rapid ventricular response, it can look regular at times. And you can be confused. When it goes very rapidly, it can look quite regular. So that's another, so we'll put down atrial fibrillation. And that's greater than 350. Okay. So what I've put here really is the atrial rate, and then the ventricular rate is the same here, about the same here in sinus tach, probably the same here in PAT. In digitalis-induced PAT, the ventricular rate is usually less, right, because you have PAT with block, right? So the ventricular rate is less here. Here the ventricular rate is almost always less. I mean, it'd be hard to imagine somebody going along with a ventricular rate of 300, wouldn't it? So here it's always less, and of course here with fibrillation it has to be less. Okay? Okay, now let's talk a little bit about the differential diagnosis of some of these, because this is where you're going to have your problems. You're going to see patients coming in this group here, from number 3 on, that you may have trouble in differentiating when you're looking at the monitor, for instance, in the operating room. You're going to want to know how to differentiate these. And just looking at the monitor very frequently, or just a rhythm strip on the electrocardiogram, you cannot tell. You can't tell. So we could use the guidelines to help us in terms of rate if we can see the P waves, and but it can be very difficult. Well, one of the first things we want to do is to be able to find out how to look for P waves on the electrocardiogram. In order to diagnose this type of rhythm, we want to be able to find out what leads do we see best P waves in. So what leads are those? Yeah, lead 2 is a good one. And another one? AVR is usually not that good. V1 is a lead that a lot of people take. A standard lead that people take is lead 2 and lead V1. But let me just point out something that we always have trouble with. And that is that anytime you're trying to evaluate an arrhythmia, you should take an entire electrocardiogram, because so often we see that long a strip of lead 2 with no information on it, and then we'll get lead V5 which has 3 beats on it with beautiful P waves. So it's really worthwhile just to look through an entire tracing before you take your long strip, your long rhythm strip, you're trying to evaluate the arrhythmia. Right? It's just common sense. And very often we'll see it in a lead that you don't expect to see it in. Now some other leads that are good to take. There's a CF lead, which if you have some of these old type of electrocardiograms, they have a CR, CL, CF. And in a CF, what you do is you put the electrode in the V1 position, and you dial all the way around to CF. And it's getting the difference between chest to foot, the CF lead. Okay, so you can try that one if your machine has a capability of doing that. Another lead that some people try is a Lewis lead. I haven't had too much luck with that, but some people recommend using the Lewis lead. What you do is you disconnect the right and left arms and you put a strap around the chest. And the plates that were in the right and left arms go in 2 positions underneath this strap. And you set your electrocardiogram onto lead 1, and you record the difference between these 2 electrodes on the chest. Right? Everyone understand how to do that? I haven't found it too useful, but you might. I haven't used it that often. Now there are some more things that you can do, right, such as what? What other kind of things maneuvers can you do in order to look at P waves? Right. Esophageal leads. On this, it's like an NG tube. You put it down behind the heart, the level of the atrium, and you pick up very nice P waves. And then also, finally, you can put in an atrial wire. Wire up the vein and into the right heart. It's like a CVP line. Right? And you can record very nice P waves that way, and then see what their relationship is to the QRS. Okay, so these are different ways of looking at P waves, which can be helpful. Okay, now let's get back to the problem. How are we going to differentiate these 4? Now you may say, well, there's really no problem here in differentiating a flutter from a sinus tach, right? Because flutter, maybe at the best, a sinus tach goes around 150 or 160, and this is up around the 300 range. But is that so? Not at all, right? Because the most common way flutter appears is how? Low. Yeah, with 2-to-1 block. So if you have a flutter with an atrial rate of 300, you wind up with an electrocardiogram having a rate of 150, and it's right in your sinus tach range. Right? So you have to see what is P waves, and it's very difficult to differentiate when you have a very rapid tracing, as I'm sure you all know from bitter experience. So then how are we going to differentiate these? We've taken our best leads that we have available, and all we see in an electrocardiogram is something that looks like this. Right? Goes very fast. Well, maybe not like that. That would look like ventricular tach. Say it's just going like this. Right. You say, are these P waves, or these T waves, or what are they? So how would you differentiate? What maneuver can we use to help us differentiate? Very valuable maneuver. Carotid sinus pressure. Okay, carotid sinus pressure. Okay, so what's the response of sinus tach to carotid sinus pressure? What'll slow down? Well, you're hooked up to electrocardiogram. What happens here is your atrial rate slows down, and this is your ventricular rate. Your ventricular rate follows it, right? You're pressed on your carotid sinus here. So you have a temporary slowing of the atrial rate, and the ventricular rate follows it. That's the classical response of sinus tach. Okay, now what happens with PAT? The same? No. No. And in the regular type PAT, there's a difference between these two types of PAT. But in the regular type of PAT, you have either an abrupt response and a conversion thereafter to normal sinus rhythm, or you have no response at all. Right, this is the usual response then to PAT. Okay. Now how about the digitalis-induced PAT? What does that do? Well, you have a different response here. Your atrial rate remains the same. Your atrial rate remains the same. But when you press on the carotid sinus, your ventricular rate will transiently slow down and then speed up again. You have a gradual slowing of the ventricular rate. So what you've done here is you've induced AV block. Right? Your atrial rate remains the same. Your ventricular rate slows down. Okay, so do you see the difference here? Sinus tach, they both slow down transiently and then speed up again. In PAT, atrial rate, the ventricular rate follows the atrial rate, and either you have a response or you have no response at all. Okay, whereas in your digitalis-induced PAT, and your flutter, and your atrial fibrillation, all these three, you have the same response. The atrial rate continues along exactly the same, and your ventricular rate transiently slows down.
Does that apply even in cases of PAT with hip toxicity when there isn't a block initially?
Yes. Yes, PAT with latent block, you mean? That's what they call PAT with latent block. And the block is then brought out by carotid sinus pressure. That's why they call it latent block. It's there, but you have to do something to bring it out. It's latent. And you get the same response. Okay. Whether the block is there originally or not. Okay, so then you come down. So now we can very nicely differentiate sinus tach, PAT, the regular type, but we have some trouble with these three. The digitalis-induced PAT, the flutter, and the atrial fibrillation. And we have some trouble with those. Okay, now how do we differentiate those? Okay, we've pressed on the carotid, and we've separated out various possibilities. Now, several things we can look at here. Let's make a little table up here. PAT, dig. Then we have here flutter. And then we have fib. Okay, and we look at such things as the baseline. And we look at such things as the P-wave configuration and the rate. Okay, going back to the rate is going to help us, right? Because the PAT rate is between 150 to 250. So usually a PAT rate is a little slower than a flutter or a fib rate, right? Okay, so the rate will help us a little bit there, differentiating these three. Okay, this is usually greater than 250, and this is greater than 350. Okay, now with PAT, digitalis-induced, what you'll get is a flat baseline. Your baseline will be flat. Here, with flutter, you'll have an undulating baseline. And with fibrillation, you'll just have a coarse baseline. And I think this is best described by my illustrating it. With PAT, you'll get it'll look like this. small discrete P waves, right? These small discrete P waves, whereas flutter looks like this. You have an undulating baseline, just a sawtooth pattern, characteristic of flutter. Whereas your atrial fibrillation, as you know, you'll just have a very coarse, uneven baseline. Now, this is a very important differential, right? But it can be very difficult, and you have to use clinical judgment as well as all the information that you have on the EKG. And this is one of the most difficult problems in cardiology, really, sometimes, is differentiating PAT with block from flutter. It may have sounded easy, the way I just described it, to differentiate, but it really isn't. And the importance of it is that if it's digitalis toxic PAT, you want to stop digitalis, certainly. By all means, you want to stop digitalis. Where if it's flutter, one of the treatments for flutter is to give digitalis. So if you make a mistake, it can really be lethal, very dangerous. Now, irregular. Let's talk about irregular atrial rhythms now. Okay, we'll go from the least irregular to the most irregular. And probably the least irregular is the sinus arrhythmia, as you are all aware about. I've seen many times. And that's the normal speeding up and slowing down of the heart rate with respirations. Right? As you inspire, it speeds up. As you expire, it slows down. Normal phenomena. Okay. And then, as you develop a little atrial irritability, we'll get an occasional premature atrial contraction. An occasional premature atrial contraction. And you're aware of what they look like as you're going along your regular rate right here. And then you'll see a premature atrial beat. And generally, a premature atrial beat will be earlier. The P wave will have a slightly different configuration. The PR interval may vary, be different than this normal PR interval. But the QRS will look exactly the same. Right? So you see a beat that's earlier. You have a P wave with a different configuration, usually, and frequently a different PR interval. All right? And the QRS looks virtually identical to normal. RR interval gets shorter. Yeah, because it's premature. Yeah. Okay, and then, so the RR interval to the next beat, it's always longer. You always have a longer RR interval, but you may or may not have a compensatory pause. They used to say that you only have compensatory pauses with PVCs, but this isn't so. You can have compensatory pauses with premature atrial beats as well. But with premature atrial beats, they usually get what they call resetting, and you may not have a compensatory pause. Okay. Okay, then you want to have something that they call wandering atrial pacemaker. And here you have ectopic atrial foci from at least two different positions in the atrium. So you have P waves of at least two different configurations, other than the normal, right, with different PR intervals. And they say that you have a band in your atrial, you have a band of conducting tissue that goes down to the AV node. What they say wandering atrial pacemaker is that the pacemaker wanders down towards the AV node, and sometimes actually can go into the AV node. So you wind up temporarily with a few beats with a nodal rhythm, and then it goes back into a normal sinus rhythm again. But generally, it's just somewhat increased in the spectrum of irritability. Okay, then as you become more irritable, we have what they call a chaotic atrial mechanism. This is atrial premature beats coming from many different foci, 3 or more different foci. So you have 3 or more different P-wave configurations. But your rate, your ventricular rate is not very rapid as a result of this atrial irritability. You have a rate of less than 100. So your ventricular rate is less than 100. That's chaotic atrial mechanism, which is differentiated from chaotic atrial tachycardia, which is also called multifocal atrial tachycardia. Right? So you have chaotic atrial tachycardia, which you may have heard of, multifocal atrial tachycardia, right? You've heard of that term. Multifocal atrial tach. And this is the same thing as chaotic atrial mechanism, except that you have so much atrial ectopic activity that your rate is greater than 100. You wind up with a rate of greater than 100 because of all of this ectopic atrial activity. And you have very bizarre-looking P waves on these tracings. Okay. This is usually a very transient phenomenon seen in acutely ill patients. In other words, patients that are just about ready to go into atrial fibrillation for a few hours or days, then may go into be in this type of a mechanism. And as they're going out of it, again, they may transiently go into this type of a mechanism. Right? And it's usually associated with acutely ill patients. And the important thing about this is to treat the underlying cause. Don't give them digitalis. Digitalis can be dangerous in these patients. The main reason digitalis is dangerous is this very frequently occurs in patients with chronic lung disease who develop a pulmonary infection on top of their chronic lung disease, and they become very hypoxic. And digitalis is quite dangerous in somebody who's hypoxic. So that's why I think it's said that digitalis should not be given to these people. So what you do is you treat the underlying problem, you treat their hypoxemia, you treat their infection, and this will generally go away. Any questions about that? Chaotic atrial tachycardia. Multifocal atrial tach. There's been quite a bit written on this. I can refer you to some articles if you're interested in hearing more about it. And then finally, atrial fibrillation. Multifocal atrial tach is a pre-fibrillatory rhythm, and these patients frequently then wind up in atrial fibrillation. Okay, so if you're just looking back over the big picture here, this is just the spectrum of atrial irritability, right? From least irritable to occasional PACs, wandering atrial pacemaker, chaotic atrial mechanism, to the tachycardia, and then on to atrial fibrillation. Okay, now let's go down towards the node. We're not quite in the node yet. So we'll talk about some rhythms that are borderline between the SA and the AV node. Okay. Now here we have several situations. Okay, here's a normal atrial beat. Now our normal sequence. Now suppose you have something that looks like this. What kind of beat is this? Right, you have an inverted P wave. Usually, let's say we're looking at lead AVF, 2, 3 and AVF, where the P waves are usually upright. So in the same leads here, now the P wave is inverted. So what are we dealing with? No, not necessarily. Could be an ectopic focus where? Where in the atrium? Low in the atrium, okay? Low atrial focus, called a coronary, we call that a coronary sinus rhythm, or a low atrial. A structure low in the atrium is the coronary sinus, so some people call this coronary sinus rhythm. And it's important because you don't want to mistake this for a nodal rhythm. So how would you differentiate this from a nodal rhythm? There's no what?
P wave.
There may certainly be a P wave in a nodal rhythm, but what's the difference between a coronary sinus rhythm and a nodal rhythm? It's the PR interval, right? What's the lower limit of normal for the PR interval? 0.12, right. 0.12 is the lower limit of normal. So if it's greater than 0.12, you're in the atrium, right? So if you have an inverted P wave and the PR interval is greater than 0.12, it's an atrial mechanism or a coronary sinus rhythm, right? If it's less than 0.12, you have a short PR interval, right? That would make it a nodal rhythm. Okay, so the differentiating point is the PR interval, right? If the PR is greater than 0.12, coronary sinus rhythm. If it's less than 0.12, it would be a nodal rhythm. Now, every now and then we see a patient that has something that looks like this. A short PR interval, but an upright P wave. What do we call that? A short PR interval, but an upright P wave. Increased excitability? It's like the Wolff-Parkinson-White, but it really isn't, because with the Wolff-Parkinson-White, remember, we have a delta wave and some other different things. You get widening of the QRS. Whereas here, there's no widening of the QRS, it's just a short PR. They call this a coronary nodal rhythm, coronary nodal, or this is also called the LGL. The LGL, or the Lown-Ganong-Levine syndrome. Lown-Ganong-Levine. We see this not infrequently. And what's happening here, as you said, it's very much like the Wolff-Parkinson-White. The Wolff-Parkinson-White, you have an accessory pathway coming around, right? But it's thought that with the LGL, what you're doing is really you're bypassing the node. You're bypassing the usual delay at the AV node and coming right down. There's another bypass pathway. Okay, and again, these patients also have episodes of PAT, very much like those with WPW. Okay. So you know now how to make a differential between a nodal rhythm and a coronary sinus rhythm. That's an important point. Make sure you're not dealing with a nodal rhythm. Okay? Now let's talk about the node. Okay, here's our node, right? Coming down here from the SA node. Here's the AV node. And we'll have three regions, high, mid, and low. And down here is going down to the ventricles, right? It's sort of a little way station on the way to the ventricles. Okay, but we can have ectopic impulses that arise from the node, and it's said that they can arise from these three different areas of the node, high, mid, and low. Now, if they were to arise from high in the node, and this were a race, let's say it's like a race. They start here, and they're heading down and up at the same time. The high node, where's it going to get to first? It's going to get up first, right? So we're going to wind up with a P wave, which is inverted, right? But it's going to be located before the QRS. Whereas if we have a low nodal rhythm, where's it going to get to first? It's going to get down first, right? So what we're going to see is the P wave following the QRS. Okay? And if we have a mid-nodal rhythm, what's going to happen? No P wave, right? You're going to lose your P wave. And they say that the P wave is really lost in the QRS complex. And this is the most common thing that we see. And I've read someplace, and I suspect that this probably isn't the sequence, that this isn't really what's taking place at all, just a way of thinking about it. Right? It's a nice way of thinking about high, mid, and low nodal. What's really taking place is that you have varying degrees of retrograde block. Right? In other words, these impulses start here, and they go up, and they're partially blocked, or they're completely blocked. So let's just think of what might happen. Suppose we're dealing with a high nodal rhythm. Do we have a lot of block or not very much block? Little block. And what would mid-nodal be then? Well, high node would be just a small amount of block. Low node would be some more block, right? Because it's coming later. Whereas mid-node, where we don't even see a P wave at all, is probably due to what? It's probably complete block. That's why we don't see the P wave. See? So I think that's a better explanation than to say that that P wave is lost in the QRS, though that could be what's happening in some cases. Okay. So nodal beats can have these configurations on the electrocardiogram. They can have no P wave. They can have a P wave preceding or a P wave following the QRS, right? And the QRS looks identical to normal. It usually looks perfectly normal, okay? And then you can have nodal premature beats. You can have nodal escape beats. Irritability of the node, increased excitability. You can have the node escaping at its own intrinsic rate. You can have nodal tachycardias. Right? Nodal tachycardias are usually divided into two types, what they call the non-paroxysmal nodal tachycardias and the paroxysmal. And the non-paroxysmal usually have rates of about 60 to 100, and the paroxysmals usually have rates of greater than 120. I think it's greater than 120. So these are your slower ones, and these are your faster ones. And both of them are frequently associated with digitalis intoxication. Probably the most common cause of both of these nodal
mechanisms.